right, thank you very much for inviting me here today. Thank you to a very entertaining first part of the debate. I'll try to make you guys laugh as much as I can, but I don't think I can compete with Dr. Pass with that one. I'll try to compete on the treatment side of SBRT. That also may be a difficult challenge, but let's see what we can do. Disclosures or NIH federal funding. Biggest disclosure is I'm a radiation oncologist. So let's take a look at SBRT first before we start comparing it to surgery. So you've heard many names, SBRT, SABR, essentially giving high doses of radiation over what now in the US we define as 1 to 5 fractions. And let's keep that in mind as we talk. So 1 to 5 fractions of very high dose radiation to tumors less than 5 centimeters, knowing where the tumor is at all times in 3 dimensions. Very complicated treatment, as you can see, compared with traditional radiation where we're doing 3, 4, 5 fields of radiation. These are either 10, 11, 12 fields of radiation or an arc around the patient where we're treating a tumor continuously to try to make the treatment as conformal as possible. So early results. So as Dr. Pass pointed out, we don't have a lot of 5-year data with SBRT. We do with conventional fractionation, and the results were awful. So if you look on the left here, the 5-year overall survival with conventional fractionation in patients with stage 1 lung cancer is only about 15 to 20%. So that number should be somewhat in north of 60% with surgery. With SBRT, very early studies, which now we really wouldn't define these as SBRT, but the first forays into hypofractionation, in 2 and 3 years, we generally saw about 60%. So it looked encouraging. Obviously, prospective studies were needed, and these were the first prospective studies that were done. These were also doses that we wouldn't really use today. So most of these were in 3 fractions at 45 gray, whereas to give you a sense, a standard 3-fraction regimen of SBRT is 54 to 60 gray, so much higher biological doses. Nonetheless, we saw local control somewhere around 80 to 90% as opposed to 60% with conventional fractionation, and 3-year overall survival around that same 60% number that we expected. So as I thought would happen, a critique, not enough 5-year data. I 100% agree. And unfortunately, we're not going to solve this problem real soon, and I'll explain that. That being said, we do know in stage 1 lung cancer, over 80% of all recurrences happen in the first 2 years after SBRT. Somewhere around 90% of recurrences happen in the first 3 years after SBRT. So if we show good 3-year data, can you extrapolate to 5 years? Probably not. That being said, most of the differences that we saw in the first 20 minutes of this lecture debate, the survival differences from 3 years to 5 years were primarily driven by patients that were being treated. An 85-year-old is much more likely to die before they reach 90 from other causes, and not necessarily from lung cancer recurrences. We do have a little bit of data, but let's look at the first cooperative group study that looked at SBRT. This is RTOG 0236, 55 patients, T1, T2, receiving SBRT to a real modern dose. At 3 years, local control, 98%. So that's really as good as you can get, as you would see with surgery. Local regional control, excellent. Overall survival, about 56%. So still not good, but keep in mind, these are medically inoperable patients. Much better than 15 or 20% with conventional fractionation, and getting close to what we would expect with a medically operable patient. The toxicities were pretty low in this study. Despite it being an early adoption of the technology, only 3% grade 4 toxicity, no grade 5 toxicities. And they actually did a nice job of looking at PFT changes before and after treatment, and there were none. So fortunately, from a long-term standpoint, from lung function, there wasn't a difference. So this was 3 years, 96% were great as radiation oncologists. Well, what about longer follow-up? So 3 years later, there was an update to this analysis, and the local control remained at 93%. So we're still north of 90% now at 6 years on this study. But not all SBRT is equal. So a lot of the earlier SBRT studies that I showed you, and a big problem with some of the earlier population-based studies that we talked about, whether it's the National Cancer Database or SEER, is they used early integration of SBRT. And that's because, for instance, with the National Cancer Database, we don't have survival beyond 2011. So all of the studies that we're looking at, the survival is really being driven by patients that were treated from roughly around 2000 to 2011, and some of these earlier publications with an earlier version of the National Cancer Database cut off the end survival date at 2008. So before that, we really didn't use high ablative doses of SBRT. And this is a good example of that. So this is an early publication of the concept of what really defines ablation for SBRT. there's something called a biological equivalent dose. So if I give somebody 60 gray in 3 fractions, that's a lot more potent than a traditional locally advanced dose of 60 gray over 30 fractions. So on the left, you can actually see giving a biological equivalent dose of greater than 100, which is essentially a 3, 4, or 5 fraction regimen of SBRT in the 50 to 60 gray range. The survival is actually dramatically better than if you give an SBRT dose below that. And local control, you can see, again, I don't have a pointer, but there's a slight decrease in local control. Oh, nice. From 100% to about 90% at 2 years. And beyond then, this is many hundred patients. Local control remains even out to 10 years. So if we're giving true ablative doses, we're not seeing late failures with SBRT. Whereas if you're giving lower doses, which is what these earlier NCDB and SEER studies look at, beyond 2 years, you're still seeing a lot of failures. And that continues to go down. And that's really what's driving this overall survival benefit. Now, if the local control is continuing to be 85, 90% at 10 years, if only about 15% of patients will fail in the nodes and distantly, why is this going down? Well, because these are medically inoperable patients. So that's what's driving the survival difference. SBRT is not equal also because of surgical, just like surgical volume, where Dr. Pass's mortality rates are going to be very different than what you report in a national cancer database or some population-based study. His overall survival is going to be very different than that 60% number for a typical stage 1 surgical series. The same actually holds true for SBRT. It's something that we didn't really appreciate until this last year, a publication in press now, but a presentation at Astro showing the volume of SBRT significantly impacts not just local control, but overall survival on these patients. This is looking at the NCDB, patients treated at a high volume center versus a low volume center without adjusting, because we know that high volume centers are more likely to be academic or different types of sort of conditions factoring patients why they would be at a high volume center. But there's a clear survival difference, 36 months versus 42 months at a high volume center. When controlling for age, comorbidities, other factors that predicted a high volume center, that separation actually increased even more. And it doesn't take much. So centers that are doing just 1, 2, 3 cases, their survival is going to be a lot lower than just 9 cases a year, let alone an academic center where a provider may be doing 100+ cases a year. All right, so let's delve a little bit into this. I think Dr. Pass did a great job. We heard that there are differences in types of surgery. Very, very early report, but I think this lung cancer study group shows that a lobectomy or at least some type of anatomical resection has a better local control overall survival than sublobar or certainly wedge resection. So a lot of the comparison I'm going to focus on outside of this one study is surgery as a lobectomy. But this study did not. So this was a closer to apples comparison of patients who were not able to undergo a lobectomy because of morbidities. All patients either got SBRT or a sublobar resection, generally a wedge resection. And even in these apples-to-apples patients who couldn't tolerate a lobectomy, patients that got SBRT tended to be older and have a higher comorbidity index score. The interesting thing that came out of this was SBRT actually had higher local control. So it doesn't make sense, right? As we're essentially a wedge resection, SBRT, we're essentially treating the same area. So why would that be? So I'll give 2 potential hypotheses if we actually believe this data. The other things that we saw out of this study was there's no difference in cause-specific survival. So patients were just as likely to die from other causes or from their lung cancer. And SBRT had lower overall survival that was driven by the comorbidities. So there are 2 potential reasons that SBRT could have better local control than a wedge resection. One is there is some dose spillage around the area outside of what a wedge would treat. So a wedge is essentially taking the tumor out and a margin around the tumor. SBRT is doing that with high-dose radiation, but there is some low-dose radiation that could potentially sterilize some microscopic disease. A second one may be immunologic-based. So there's a lot of literature suggesting that surgery can actually decrease immune response, whereas SBRT may be able to increase immune response. This was an example of a patient we treated at Penn, actually, a little bit different population, and this patient was a metastatic patient receiving an anti-CTLA-4 antibody along with SBRT. Had a very symptomatic, you could see sort of in the pelvic gluteal area, and so in the top, can I get that? Oh, good. So this is the area that we wanted to treat. Simple SBRT, to interdigitate between his anti-CTLA-4 therapy, just get done treatment real quick. And when we treated that, he had a great response, as you'd expect with SBRT. The interesting thing that we saw was areas that we didn't SBRT actually disappeared too. So here's liver met in the abdomen. This has been shown, this is what's defined as an abscopal effect. So even though we're giving radiation to one area, immunologically, the radiation may be inducing an immune response to now make either the body's own immune system more effective at attacking cancer, or any targeted or checkpoint inhibitors or other therapies more effective at treating cancer. So can the same concept apply in just stage 1 lung cancer? Maybe, where the radiation is doing a lot, ablating, killing 99.99% of the tumor cells, but that immune response that it's generating can take care of any other residual tumor cells that are left. So again, I don't want to go into all the studies because I could do the same thing as far as showing a whole list of studies where radiation was shown to be better than SBRT. I'm just going to show one because I don't want to bore all of you. This was a meta-analysis. I actually thought it was a pretty good one because it was the biggest one that I know of at the time. 40 SBRT studies of nearly 5,000 patients, 23 surgery studies of 7,000 patients. And what you saw, as expected, SBRT, they're older patients. When you don't account for comorbidities or age, those are the only two factors we're looking at, unadjusted overall survival clearly better with lobectomy. This study also looked at sublobar resection, much more comparable to SBRT, but unadjusted overall survival, lobectomy better. Adjusting for age and looking at the operable patients, the numbers are actually reversed. SBRT is the blue line here, so actually on top. So after the sort of controversial SBRT versus surgery, quote, randomized trial came out, I was asked to do a commentary. And at that time, this was at the end of last year, I did a thorough review of the literature. And there are 4 main groups of studies that have been published. One are retrospective analyses. Let's throw those out. The William Beaumont study, SBRT looks great. Let's not kid ourselves. There's propensity score match analyses, population-based analyses, and systemic meta-analyses. Essentially, the interesting thing, so Dr. Pass showed 2 population-based studies, one National Cancer Database, one SEER from the Yale group. There's actually a third one from the Yale group that was written as a first author by a radiation oncologist, showed that SBRT has better survival. So what I found in doing this review, whoever the first author is of the paper is going to show that outcome of that modality is better. Another interesting thing, this was the most recent data that I have. It was a big talk at the World Lung Conference last year. Not published yet. I tried to look again last night. So 20 studies, comparative effectiveness, surgery versus SBRT. 12 studies show no difference between surgery and SBRT. And some of them controlled for things like age and comorbidity, some of them didn't, but the bottom line is those 12 studies, no statistical difference. 8 actually showed surgery was better, and none of them controlled for baseline comorbidity and age. So I think the preponderance of literature says, maybe lobar, an anatomical lobe resection is better, and the ones that I think probably, although you can't tell this from these types of studies, that you'd see a real benefit on are greater than 3, particularly greater than 4 centimeter tumors. Younger patients, they may live longer to 1, fail, and 2, they're going to be more likely to have a good recovery from surgery, less risk of morbidities. But I think the sort of take home from this is, really, it is who's writing the study and what they're controlling for, what propensity match scoring they're used, and everything else. The one thing I do want to highlight is, and this is an important point to keep in mind as you're reading these studies, a stage 1 surgery patient is not the same as a stage 1 SBRT patient. We know that of all patients that are thought to be clinically, based on a PET scan, stage 1 non-small cell lung cancer, about 15% of them are upstaged at the time of surgery. And some of those are found to be N1 patients, some of them are found to be N2 patients. And there's another 15% of patients that aren't going to be found to have stage 1 non-small cell lung cancer at all, or non-small cell lung cancer at all. So surgery has the advantage of saying, a stage 1 patient is a true stage 1 patient, whereas SBRT, some of those patients that are being compared, they're not actually stage 1 patients. So you're really comparing stage 1 surgery patients versus 85% stage 1 radiation patients and 15% stage 2 and 3 radiation patients. So keep that in mind as well. So medically operable, we do a little bit better, and these patients are more likely to be staged thoroughly. So these patients can tolerate Dr. Vachani and colleagues doing an EBUS on these patients or a mediastinoscopy, and certainly PET scans in a prospective study are more important. But this is a large study, so this was over 660 medically operable patients, and as you saw, local control, very, very good. Disease-free survival is actually 89%, so better than I would actually expect, and I think that's because these patients were staged so well. Local control well in excess of 90%. 3-year overall survival, 80%. The only other prospective cooperative group medically operable study was done by the RTOG. This still isn't published yet, but encouraging very early results at 2 years, 84% overall survival. So that's better than we've seen with any other SBRT medically inoperable series. We certainly need prospective randomized data comparing it. There have been 3 attempts at it. The Roselle was led by the Netherlands. The STARS trial was US-based, but an international trial. And the ACOSOG, the surgery group, and the RTOG, the radiation group, tried to do a combined trial. All 3 closed due to poor accrual. The only study, and take this with a big, big grain of salt, that was published out of those was a pooled analysis between the STARS and Roselle trial. To give you a sense, only about 3% of all the patients that were expected to be accrued to these studies were actually accrued. And combining studies is never a good idea. That being said, they did it. It got published in Lancet Oncology and did make a lot of headlines. So 58 patients were analyzed. 3-year disease control, no difference. So local control, nodal control, distant control, SBRT, surgery, same thing. The surprise actually was that SBRT had higher survival. I don't know if we should really take that for anything more than, a pooled analysis of 2 failed studies. But it does highlight that there is a mortality associated with surgery, and that's probably what drove the survival difference. The toxicities were pretty different. In surgery, there were 4% with grade 5 toxicities, and about half of all patients had a grade 3 or higher toxicity. With SBRT, there were no grade 4 or 5 toxicities, and 10% with grade 3 toxicity. So the conclusion from this, the authors had it worded for them, confirmation of at least clinical equipoise between SBRT and surgery. One other thing that came out of this prospective study, the Roselle study actually did a very thorough job of looking at quality of life patient-reported outcomes. And what they saw from before to after treatment, SBRT was associated with better global quality of life as well as dyspnea, and pain. So that may be a little bit of a driver for SBRT in that regard. Also, when considering hospitalizations and those costs, SBRT had a lower associated cost. And that's been shown by 2 different SEER analyses as well that was able to capture hospitalizations and costs. So hopefully we'll have an answer, because there is no equipoise in the topic right now, that's for sure. These are prospective studies that are open or will open. The Valor trial is going to be in the VA system. Sabertooth is being activated in the United Kingdom, and I actually think that both of those have a real chance of accruing because the medical systems are a little different than the payer system in the US. PostLive is actually accruing very well. This is an RTOG radiation-sponsored trial, but being conducted in China, and it's already accrued a good number of patients. And then Stablemates, which is actually a reincarnation of the ACOSOG RTOG trial, that's already started to accrue. And they've already accrued and just opened this year. They've accrued as many patients in this calendar year as the initial trial did in something like 5 or so years. So the last 3 minutes, I'm just going to talk about potential benefits of SBRT. We're not going to be able to say SBRT is better than surgery or lobectomy in healthy patients, but what are some potential benefits? We heard about this histologic confirmation. This is true, but our surgical colleagues take patients to the OR pretty often without tissue diagnosis, and this is actually the American College of Chest Physician guidelines that if there's a nodule that's suspicious and the clinical probability of malignancy is greater than 65%, you should do empiric surgery. Now, sometimes that can mean a wedge resection in the OR, get frozen, see that it's a malignancy, and do a completion lobectomy. But think about it. We don't have a lot of data to say, and we have no data to say that pathology and histology actually hasn't any impact in stage 1 lung cancer. That molecular information's not currently usable, and you'd really want to repeat that molecular analysis at the time of recurrence, and we currently aren't using any targeted therapies for our stage 1 patients off trial. Is SBRT empirically overtreating patients? Well, probably not. At the bottom here, this was the largest study looking at empiric SBRT versus SBRT for histologic confirmation within a single group. This was in the Netherlands. Local control, regional control, distant control was the same. So I think if you use judicious use of the technology, looking at size, some of the things that Dr. Vachani talked about earlier, as well as PET avidity, speculation, smoking history, I think we can in some patients, avoid potential toxicities of a biopsy, but that shouldn't be the standard of care. We should still be knowing if these patients have cancer or not. Patient convenience is another one. So surgery, obviously, multi-day hospitalization. SBRT, outpatient therapy, generally 5 or fewer days. According to RTOG 0915 that was just published at the end of last year, maybe as few as a single day of treatment. So this was a study of 1 fraction versus 4 fractions, and there's no difference in local control or overall survival. SBRT certainly, I think, has the head-to-head for medically inoperable patients. It goes without saying there are a whole host of reasons that potentially patients can't have surgery. What about age? Now, this one's a little controversial, but I'll just have 2 slides on this, and then we'll wrap up. But this was a VA publication looking at patients, about 3,000 that had lobectomy, and just looking at the lobectomy patients, excluding the pneumonectomy patients, 30-day mortality from a lobectomy, 4%, and about a quarter of them had a 30-day morbidity. Looking at the largest SBRT study published to date, those numbers are less than 1% mortality with SBRT and 3% morbidity with SBRT. And the other thing to look at with this is, so while that 4% to sort of 3%, 4% as patients are in their 50s and 60s, as patients are getting above 70, you're in the double digits according to this analysis for operative mortality. This is a similar study done in the UK and in Danish registries, in total over about 6,000 patients, and they showed similar, about a 5% operative mortality. This is at 90 days, and here age made a difference. So good performance status less than 70, 2% operative mortality. Poor performance status greater than 80, 17% mortality. So these are not Dr. Pass's numbers, no question about that. But it does go to show that older patients, you need to be a little bit more careful and more judicious in who you operate on. And SBRT, I don't think we have that same concern. So this was the biggest study published in patients who are older. So they define this as over 75 years of age, 200 tumors. And essentially local control, same 90% that we've seen in other studies. Toxicity was really limited. So these are all grade 2 toxicities. There's no grade 3, 4, or 5 toxicities in this 200 patient cohort. And when they actually did a case match to younger cohorts in the same institution, there's no difference in outcomes for their patients. And then lastly, COPD. So certainly most of our patients are going to have COPD. That doesn't exclude surgery, doesn't exclude radiation. I think the patients with severe COPD, that should be something that you should consider SBRT for. There are only 4 studies in this systematic review that included patients with FEV1s less than 40. A local control, whether you had SBRT or surgery, was excellent, around 90% or higher in all studies. But the 30-day mortality was not trivial with surgery, 10%, where it was 0 with SBRT. So in conclusion, lobectomy is and rightfully should be the standard of care for medically operable patients right now. It's not without cost, though. So morbidity of pain, dyspnea, certainly a small but real number of mortality risk. And then there's hospitalization, time, expenses, as well as loss of productivity of patients and wages. We know that SBRT is replacing conventionally fractionated radiation therapy. Not all SBRT is the same. So you really need ablative doses, BED greater than 100, ideally at a high volume center. And we really should be doing this in conjunction with our multidisciplinary specialties in radiology, in either surgery or in interventional pulmonology to stage these patients properly to know that they really are stage 1 patients. The one thing that I think is incredibly neat and at a time constraints didn't show, there are now 3 different population-based reports that have shown the overall survival of lung cancer has gone up over the last decade. That increase has not really been driven by a whole lot of advances in the higher stage patients. It's actually being driven in patients that used to not get any therapy because they were too sick to tolerate surgery, couldn't tolerate coming in for 7 or 8 weeks of conventional radiation. Now they're getting SBRT, getting cured, and that's driven the entire population-based survival of lung cancer up. We may have similar survivals to medically operable patients. Too early to know for sure, but it does appear that there's, quote, at least clinical equipoise in some people's minds right now. And then there's some benefits. So elderly, significant comorbidities, COPD. There may be some immunologic benefit to SBRT as well, and we can do empiric treatments if needed. Reducing morbidity is also a benefit. And one thing that Dr. Pass's group actually showed very well is a lot of patients that standard of care, stage 1, first lung cancer, get surgery, but a large portion of those patients are going to get a second lung cancer. Do you want to do a second lobectomy or do we want to do SBRT on those patients? Thank you.